I would like to invite our next speaker on stage, Dr. Iodine Reghunadhan. Dr. Iodine is a senior consultant in comprehensive ophthalmology and refractive surgery at Chaitanya Eye Hospital and Research Institute in Trivandrum. Today she'll be talking about the key diagnostic tests and what's new. Over to you, Dr. Iodine.
Good morning, all. Thank you, Dr. Divya and KSOS for this opportunity. I will be dealing with the key diagnostic tests in dry eye. So, the signs and symptoms of dry eye disease are poorly correlated. As such, there is no single gold standard diagnostic marker described for dry eye. And as Dr. Divya mentioned, the sequence of testing recommended is from the least to the most invasive. The TFO's DS2 diagnostic methodology report was published in 2017 along with the revised definition for dry eye. It gives the recommendations under these headings starting from symptoms to the eyelid aspects. We will start with the symptoms. These are one of the validated symptom questionnaires is recommended. The one which is recommended is the OSDI, which is the most common, the DEQ5, which is shorter, and the Sandy questionnaire, especially for repeated assessments. Next is a visual disturbance, again with the questionnaires, functional testing, and functional visual acuity, which is done with the patient wearing his habitual prescription after 10 to 20 seconds of sustained eye opening without blinking and aided by anesthesia. Next is the tear film stability. Here we have the tear breakup time. It's the interval of time between the complete blink and the appearance of the first break in the tear film. When done with fluorescein to enhance the visibility, it's a fluorescein breakup time. More than 10 seconds is considered normal. And when it's done without fluorescein, it's a non-invasive breakup time, which is typically longer than the fluorescein breakup time. Whenever possible, the recommended one is the NIBT, but since it requires special machines, the FBUT can be used whenever NIBT is not available. Next is the thermography. Based on the concept that evaporation of tear film causes cooling of the ocular surface. So measuring the temperature changes during the interblink period is an index of tear film stability. Similarly, osmolarity variability is also an indicator of tear film homeostasis. Inter-eye differences more than 8 millimosmoles per liter is considered as abnormal. And the tear volume, the key tests are meniscometry and Schirmer test. Meniscometry is the tear meniscus height, which is measured with special instruments. Normal is less 0.2 to 0.5 millimeters, and less than 0.2 millimeters indicates lacrimal deficiency. Similarly, we can measure the reflection from the convex tear meniscus surface. The tear meniscus radius can be measured with OCT, and it's typically lower in dry eye patients. The Schirmer test is an age-old, well standardized when done with without anesthesia. It can be done with and without anesthesia. Without anesthesia is the standardized one, and the wetting of the filter paper strip is measured. Less than 5 is considered as dry eye, more than 10 is considered normal. And it has a problem with repeatability of the testing. And however, when done with the eyes closed, it is said to be well standardized and repeatable. Coming to tear film composition, the tear film osmolarity is a single best metric described to diagnose and classify dry eye disease. 308 milliosmoles per liter is widely accepted to be more sensitive to diagnose mild to moderate dry eye disease. Now coming to damage to the ocular surface. Let's say ocular surface staining. Classically described for the cornea with fluorescein and for the conjunctiva with lissamine and rose bengal. But however, with the use of yellow barrier filter, fluorescent staining is said to be better sensitive than the conventional method. it is even compared to for the conjunctival staining, it is sensitive even better than the lissamine green with the yellow barrier filter, with the advantage that just one dye need to be used and no vital staining is required. Next is impression cytology. The cellulose acetate filters are used. The most superficial layers of the epithelium and cells are analyzed. The Nelson's classification system is used. Next is the lip cough. It's the lid parallel conjunctival folds, and this is the area to look for the lip cough. That is, the dashed line is the limbus and the vertical line dropped from the limbus. So that is the area to look for the parallel conjunctival folds, and it is graded from 0 to 3 depending on the number of folds seen. Again, next is the confocal microscopy. It's a non-invasive test. It identifies ocular surface damage at a cellular level, decreased corneal and conjunctival epithelial cell density, conjunctival squamous metaplasia, and corneal nerve changes have been described. Coming to inflammation of the ocular surface. So many inflammatory markers have been implicated in dry eye. The most common ones implicated are the TNF-alpha, interleukin 6, interleukin 17A, interleukin 8, and MMP9. Of these, the most common one used is the MMP9, and can be done with a point-of-care office test. And a positive value is seen when the MMP9 value is more than 40 nanogram per ml. Coming to the lid aspects, first is the lid viper epitheliopathy. It's the area of the lid viper, that is where the lower lid rubs on the conjunctiva. The staining produced is measured. The horizontal length of staining and the sagittal width of staining are measured, and it's graded accordingly. Interferometry, it's an ancillary test. Abnormal multicolored interferometric fringes are seen in dry eye disease. It can also measure the lipid layer thickness, which is normally 40 nanometers. Next is meibography. It gives a morphological assessment of the meibomian glands. The meibomian glands are seen as hyperilluminated areas. In between, the dark areas represent the areas of dropout. Confocal microscopy can also be used to study the eyelid margin. It has diagnostic benefits in obstructive meibomian gland disease. However, it has not been popularly used for dry eye disease diagnosis. So, coming to the clinical protocol for the dry eye diagnostic test battery, these are the TFS2 recommendations. It's a symptomatology, that is DEQ 5 more than 6 or OSDI more than 13, along with one of the markers, that is non-invasive tear breakup time less than 10, osmolarity more than 308, or an inter-eye difference more than 8. Surface staining with more than 5 corneal spots, more than 9 conjunctival spots, or a lid viper epitheliopathy of more than grade 0. Technologies coming, there is an influx of technologies into this field. I'm mentioning the trade names, but with no financial interest. This is the ocular keratograph. It gives a reading of the NIBUT, redness, meibography, dry DEQ, and TM meniscus height. This is the ocular surface analyzer, or the IDRA. Then gives the NIBUT, eye blink, lipid layer, TM meniscus height, and meibomian gland loss area. And this is the LiPi view, which gives lipid layer thickness, dynamic meibomian gland imaging, and blink dynamics. In coming to the emerging technologies, lab-on-a-chip systems with multiple biomarkers simultaneously can be tested are in the pipeline. Multiplex tiered assay devices which uses sub-micromilliliters of tears are been suggested, and diagnostic tools to assess reactive oxygen species and oxidized products in dry eye disease. Then technology to determine key pathophysiological factors such as osmolarity and inflammation real time over the whole ocular surface is a future prospect. Another one is the measurement of tear film particle dynamics, where the upward drift of the tear film is measured, and increased wettability, there is increased upward drift. It has been studied in pre-lens tear film in contact lens wearers. It can be used to study the precorneal tear film also. So with all these, where the technology meets the tears, a targeted dry eye therapy is possible. Thank you.
Thank you, ma'am, for taking us through the various diagnostic